Well, hello and welcome to Sunday Morning Coffee with Dr. Childress. Today I'm going to be discussing the Diagnostic Checklist for Pathogenic Parenting and the Parenting Practices Rating Scale. Together, those make up the diagnostic assessment for this, uh, or the diagnostic assessment protocol for this attachment related pathology in the family courts. And so I'm going to be describing both the instruments and their origin and how they can be used. This comes off of um, a response that I received from a legislator in Denmark. Somebody in Denmark provided the legislator with my work, the diagnostic checklist and parenting practices rating scale. And the legislator said, "Oh, it can't be that simple." And yes, it is. It is exactly that simple. And so I'm going to explain it because it looks more complicated than it might actually. Uh, it looks more complicated than it actually is. So the the issue in the family courts is that everybody was making things up. We had this parental alienation thing. There were no standards of practice, uh, and it was just a mess over here. Now, I'm senior staff. If you look at my vita, I'm the clinical director. I was a clinical director for a 3 university assessment and treatment center for children ages 0 to 5 in foster care. And I keep putting in that 3 university for a reason. Because if you get 3 universities involved in something, one, Loma Linda provided occupational therapy faculty and staff, and the other, Loma Linda University, provided speech and language faculty and staff, and Cal State San Bernardino provided the psychological uh, faculty and staff and trainees, postdocs, interns. And the referral source was the Department of Children and Family Services. And our funding source was the Department of Mental Health in San Bernardino County. So we were funded by county, bringing 3 universities together. This is a big project. And they were looking for a clinical director for the project. And because I have early childhood background experience, and because people who work with me know me, my name got floated to them, and they recruited me out of Jim Swanson's project down in UC Irvine on ADHD in preschoolers. And that was a good project. Jim Swanson's like the top expert in ADHD. He was one of the lead sites for the MTA study on ADHD. And I even have a journal article where I'm fourth author on my work, based on my work there. Let's see, my colleague Leanne Tam is first author. She wrote the article. She was the administrative psychologist. I was a clinical psychologist, kind of running the project. And then Jim Swanson was the second author because he was the one who developed everything. Mark Lerner was the third author. He was the medical director at UCI. And I'm the fourth author. And then there's a bunch of authors after me, because I ran the project. And so if you read that article, that's what I was in charge of running. It was parent training across the entire county using this particular type of model out of Chuck Cunningham, McMaster's University. And so just my time there generated this big multi-author study in the journal Clinical Neuroscience Research. And I was recruited out of that project to be the clinical director for the assessment and treatment center in San Bernardino. In addition, I was also recruited over, just prior to that, over to a project um, by the FEMA and the Department of Justice to develop a national model for assessing juvenile fire setting behavior. And that's a court related behavior. They wanted to know whether these kids who were set fires should be on the mental health track or on the legal track, juvenile justice track. And so they needed an assessment protocol to make that determination. So they got a hold of Ken Feynman, who's one of the top experts, was the top expert in juvenile fire setting behavior, a forensic psychologist. But he doesn't do assessments very well. The forensic people don't understand assessment. And so I was brought on as a clinical psychologist to develop the assessment protocol specifically for the pathology. And then we had Brett Patterson we brought on board. He's a organizational development psychologist to help us implement it within the local fire agencies. So I've been clinical director for a DOJ FEMA project to develop an assessment protocol for the family courts. I was clinical director for a big university project. I'm senior staff. Okay. So if you see me walk with a little arrogance or say, my diagnosis is always right, that's why I'm senior staff on this. So I come over here to the family courts and it's an absolute mess. So I started to clean it up. And the first thing we need to do is get an accurate diagnosis. So we need to get rid of all this made up pathology. Parental alienation needs to go. We need to apply established knowledge. Now, diagnosis is based on the symptoms. Okay, you tell me the symptoms, I'll tell you the diagnosis. So we need to get a clear reporting on the symptoms in order to get an accurate diagnosis. And that's in all of healthcare. Think about it. You go into a physician and you say, doctor, this kind of hurts. They're going to ask you your symptoms. How long, how much pain, where's the pain? You go in, doctor, you say, doctor, I got a stomach ache. My gastrointestinal system is acting up. They'll ask you all sorts of symptoms about that. Where's the pain? What's going on? Do you have a fever? All these kinds of things. You go in and say, I have a headache. They're going to ask you all your symptoms about that. And so based on your symptoms, they will then develop the diagnosis. The first thing that we do in healthcare, all of healthcare, is to identify the domain we're talking about. So are we talking about possible cancer? Are we talking about an orthopedic injury? Are we talking about some sort of stomach, gastrointestinal problem? Or are we talking maybe a brain tumor or something going on with the head? So we have to identify where's the location, what's the general type of pathology we're talking about. And for this pathology, it's an attachment pathology. A child rejecting a parent is a problem in the love and bonding system of the brain. That's the attachment system. So this is that's the category. We're not trying to diagnose autism or ADHD or eating disorders or substance abuse or anything else. The focus of our diagnostic assessment is on the child's attachment pathology. So that's one of the first things I came over here and started to do, was to work up the diagnostic assessment for attachment pathology. Now, I have specialized expertise in the attachment system. I have 0 to 5 mental health specialization. That's a very serious mental health specialization. You're not allowed to practice below the age of 5 unless you have mental health specialization. Because it requires knowledge of all the brain systems, language systems, cognitive systems, emotional systems, relationship systems, sensory motor systems, all of them, how each one develops, how they interact with each other, and at 3 months, 6 months, 9 months, 12 months, 18 months, 24 months, 36 months, 5 years, how they all change over time on these brain systems interacting and what they're supposed to do. That's a lot of information. And so it takes years of training. That's why I went to my pre-doc at Children's Hospital of Los Angeles, because they had Marie Polson, and she had a therapeutic preschool. Marie Polson is one of the top early childhood mental health people. And so I made it a point. I wanted to go to them. And so I spent my pre-doc there and 2 years of postdoc. Let me say something about that. We only need 1 year of supervised postdoc hours for licensing. CHLA requires 2 years for their postdoc because they need that long for the training. So they say, if you're going to come to CHLA for your postdoc, you're going to give us 2 years. If you just want to go get licensed, go somewhere else, because they need those 2 years for the quality of training that they give. They're they're under the Keck School of Medicine at USC. That's a collaborative university affiliated program at CHLA. And so I gave them 2 years because I wanted that level of training. And so with Marie Polson in early childhood mental health, you can look at my Vita. I know 2 different diagnostic models for early childhood, DC 0 to 5 and DMIC. DC 0 to 5 stronger in AD in attachment. DMIC is stronger in autism. I know 2 early childhood attachment therapies, Watch, Wait, and Wonder, and Circle of Security. Okay, and I've a certificate in infant mental health from the Fielding Graduate Institute. So I'm all early childhood kind of worked, and early childhood is the period of the attachment system. Plus, I worked in foster care, which is attachment pathology. So these people over here who are disrespecting the level of my expertise shouldn't. Okay, I am senior staff. I know exactly what I'm doing. And we need to clean this field up over here. So the first thing we need to do is get a clear reporting on the symptoms. And so I applied all my knowledge on attachment, delusional thought disorders. I worked 12 years on a schizophrenia project, being trained in the diagnostic assessment of delusional thought disorders to a 90% diagnostic reliability to Joseph Ventura and David Lukoff, who are the co-authors with Keith Nectarline, who was head of the project, of the brief psychiatric rating scale. And you can look it up. It's item 11, unusual thought content is the one for the delusions. So I was trained to 90% diagnostic reliability on delusional thought disorders to the authors of the brief psychiatric rating scale. So I'm one of the best trained people on the planet in terms of delusional thought disorders. You may go to Joseph Ventura, and he may be a little bit better on the because he works schizophrenia. He doesn't work trauma. He doesn't work child abuse. He doesn't work attachment pathology. He's a schizophrenia guy. Now, I did reach out to Joseph about a year ago, and I said, Joseph, I might be sending these family court people over to you for training in the BPRS, because he still works at Semple Institute at UCLA. So I got a hold of him and said, Joseph, I'm going to be sending these court-involved people over to you for training in the BPRS, because I think everybody should be doing the BPRS in the family courts. Why not? We need to go to the top. We need to be the best, not just lazy. So, so he does the training. So if you want to go get training in the assessment of delusional thought disorders, you can get it from Joseph, or you can listen to me, because I'm trained to reliability and diagnostic assessment with Dr. Ventura. But so I get over here. We need the symptoms. I apply my knowledge of looking at the pathology, and I identify 3 symptoms that will absolutely diagnose the pathology. But actually, it's just a 1-symptom diagnosis. It is that simple. Is there a shared persecutory delusion in the child and parent? That's it. Is there a shared persecutory delusion between the child and the parent? Yes, no. It's a 1-symptom diagnosis. However, I realize that nobody in the family courts is competent in the assessment of delusional thought disorders. It's a mental status exam of thought and perception. I can do a mental status exam of thought and perception. When I assess this pathology, I don't use my 3 diagnostic indicators. I do a mental status exam of thought and perception on the parent. And boop, we pop the delusion right out in the session. We don't make diagnoses of delusion based on history. We pop it out in the session. And we do it using a mental status exam of thought and perception. And we get to see it, we get to look at it, and that's how we can rate it on the BPRS, all its features and things, because we're actually looking at it in the session. And so that's what I do. I do a mental status exam with the parent, and then I verify with the child that they both have the same shared delusional belief. Here is the definition of a persecutory or a delusion, persecutory delusion from the American Psychiatric Association. So, from the APA, persecutory type, delusions that the person or someone to whom the person is close is being malevolently treated in some way. So that's the key thing. Does the child have a fixed and false belief that the child is being malevolently treated in some way by the targeted parent? Google malevolent, that's having or showing a wish to do evil. So, does the child have this fixed and false belief that the targeted parent has a wish to do evil to them and is malevolently treating them in some way? Yes. Does the parent, the allied parent, share that fixed and false belief? Yes. Well, then you have a shared persecutory delusion. But that would be a little uh, perhaps unstable for the mental health quality, the mental health people you have currently available. So I'm a scaffold from our current the current level of ignorance in the family courts to the next level of knowledge, to actually the application of knowledge. Ultimately, I just disappear. I'm a catalyst. I'm the bridge from ignorance to knowledge because I have the knowledge and I know what I'm doing. So, in order to help you out, I gave you three symptoms. They are each impossible symptoms. They never occur ever. And yet, all three will show up with this pathology. So, if you just identify these three symptoms, are they present or absent? In 100% of the cases, they will be absent. Except with this family court pathology, you will then see three impossible symptoms. Now, uh, so let me talk a second about just how simple these three symptoms are. So let me pull up my my slideshow here. So the diagnostic checklist for pathogenic parenting and the parenting practices rating scale that goes with it are on my consulting website. I call it my Gold Trees website. I have another one, Purple Trees, but that's offline right now. It'll come back later. I use that more for documentation. This is my active website with a lot of active information. I suggest all parents go to the attorney resource section of my website, start looking at some of those handouts, look at the risk assessment handout, look at the telehealth consultation handout, description of the pathology handout, my specialized expertise handout. I have specialized expertise in 6 domains of relevant pathology: delusional thought disorders, attachment pathology, child abuse and complex trauma, factitious disorder imposed on another, that's Munchausen by proxy, that's out of CHLA, family systems therapy, and this court involved pathology. And so that's what I've applied to developing these symptom rating instruments. So you go to my consulting website. These instruments are in the mental health professionals page. And then you click through to the consultation, mental health consultation. And I provide a description of the pathology, and then I provide these instruments. So the first, the instrument, the diagnostic checklist for pathogenic parenting is the central instrument. And it's really simple. It's just 3 really simple symptoms. Is the child rejecting a normal range parent? Okay, first off, children never reject a normal range parent. Problematic parent produces an insecure attachment that more strongly motivates the child to bond to a parent. The only time a child might reject a parent is at the level of child abuse, okay, of some kind. Physical child abuse, sexual child abuse, psychological child abuse, not really, but we'll consider it. But we're going to be talking child abuse range when we have a child who's rejecting a parent. And so this is a child rejecting a normal range parent. That never happens. In all of the rest of mental health, this pathology that you have in the family court, the prevalence is 0. That's why clinical psychology doesn't have treatment for a 10-year-old who's got severe attachment pathology. It doesn't exist in the real world. The pathology that you're trying to deal with in the family courts only exists in the family courts. That should give you an indication that it's a false pathology. Because if it was real, we'd see it across society, but we don't. We don't see it anywhere else except right in the court because we got a narcissistic dark personality who's manipulating the court by creating a false, factitious attachment pathology in the child. So that's symptom one. It's an impossible symptom. Prevalence is zero. So if you see a child rejecting a normal range parent, we got the pathology. That's what it is. But I don't trust you guys, or you guys probably don't trust yourself to make that diagnosis based on one symptom. So I gave you a couple more to confirm it so that you'll feel more solid in. The second symptom is extreme anger or extreme anxiety. That's called protest behavior. Now, these are actually volume 1 and 2 of Bowlby. So, one is on attachment. Children don't reject parent. It's a primary motivational system of the brain. It's goal corrected, which means it always maintains the goal of forming an attachment bond to the parent. If there's barriers to that, it finds other ways. It distorts itself trying to get an attachment, but it never seeks to sever the attachment bond because there's a predator out there trying to kill the kid. So over millions of years of evolution, children do not reject parents because they're eaten by predators or they starve or they get abandoned. No, it doesn't happen in children. Children, it's a goal-corrected motivational system. Mental health people learn that term, goal-corrected, primary motivational system of the brain. So we never see diagnostic. So that's Bowlby's volume 1. Now, Bowlby's volume 2 is separation. Anxiety and anger. Well, that's what we got, anger and anxiety. So I pulled those two symptoms. We're going to see high, uh, extreme levels of that symptom. And when you get the word extreme on any symptom, you're in a trauma pathology. Trauma adds extreme to every symptom. Extreme sadness, suicidality, extreme anger, rage, extreme anxiety, panic attacks. So anytime you hit the extreme qualifier to any symptom, you're in a trauma pathology. So we have attachment pathology, we got attachment trauma pathology. Just knowing right off the bat with the symptom of child rejecting a parent, that's an extreme attack. We're in trauma and we're in attachment pathology. So now, how do we define extreme anger and extreme anxiety? Well, because we need it defined for diagnostic purposes, but also for research purposes. This is also going to help a lot with the research because it gives us an operational definition for what the pathology is. At Keith Nectarline's lab on schizophrenia, my job was to run all the data aspects of the project. So I had a couple of staff that worked under me, and I was in charge of all things data at a huge NIMH research project. I know research and I know data. And one of the problems over here with no research in the family courts is we can't define what the pathology is because people are trying to use parental alienation and there's no definition for that. It's not a real thing. So the moment we move back to establish knowledge and define it as an attachment pathology, and all of a sudden we can create definitions for what this is. Then once we get the definition, we can identify the population we're working with and then their features, which is exactly what Greenham, Childress, and Pruder does in their Darkson Delusional Pathology article, where Melanie looked at Dorsey's Pruder's database on the custody resolution method and looked at the 12 associated clinical signs, which we'll talk about in a second. And sure enough, they're all present. They're not all, they're present and to high frequency, which absolutely proves that what I'm saying is right. When you make a prediction and you get the data and the data supports the prediction, that's called the scientific method. So there is zero doubt that an attachment-based model of parental alienation is accurate. Now, the way I operationally defined this for research and diagnostic purposes was extreme anger would be 5 specific narcissistic personality disorder traits in the child. Grandiosity, judging the parent, that's the inverted hierarchy. Absence of empathy, that's the capacity for cruelty. That's how we assess that absence of empathy in the child. is the capacity for cruelty. Never want to see that with a child. Haughty and arrogant attitudes, sense of entitlement, and splitting. Splitting is a very characteristic symptom of narcissistic and borderline personality. It shows up with nothing else. You don't see splitting with autism. You don't see splitting with eating disorders. You don't see splitting with depression or anxiety. You only see it with narcissistic and borderline personality pathology, and there's a reason for that. But I won't get into that. So if you're seeing splitting in the child and an absence of empathy, the absence of empathy is the core narcissistic of the personality pathology, the capacity for cruelty, that absence of empathy. And so if you're seeing those two, you got a child with a narcissistic personality disorder. And that's 5 symptoms is the criteria for the diagnosis of personality disorder. But that's impossible. Children do not develop personality disorders. That's an adult pathology. That in childhood, what later becomes a narcissistic personality or borderline shows up as an attachment pathology, as an insecure attachment. And so if we're looking at a child, we don't see we never find a narcissistic personality disorder in a child, except here. Oh my goodness, you're going to find. Why? Because a child here is being psychologically controlled and manipulated by the narcissistic borderline parent. And when the parent comes in and manipulates the child, they leave the fingerprints of their narcissistic personality on the child. It's not the child who's grandiose judging the other parent, it's the other spouse judging the spouse. It's not the cruelty of the child, it's the cruelty of the allied parent towards the other spouse. It's not the splitting of the child, it's the splitting pathology in the narcissistic borderline parent. And so that's, I call those the fingerprints of the psychological control of the child. Or possibly phobic anxiety. You'll tend to see the phobic anxiety with younger children, 4 or 5 years old, because they don't have enough self-structure, it's called, yet to develop the personality kinds of stuff. But you'll see typically borderline mom will produce a lot of anxiety around transfers. And when you look at the anxiety, you'll find it meets DSM-5 criteria for a specific phobia. But it's going to be a mother phobia or a father phobia, and that's not realistic. Again, the prevalence of a mother phobia or father phobia is 0. There's never been a case of that. If you got a mother phobia or father phobia, write it up for the journal because that'll be the first case ever. So we got 2 impossible symptoms. Guess what? They will both be present. Why? Because this is a false disorder. It's a factitious disorder, the factitious attachment pathology being imposed on the child. So you'll get all these false symptoms because they're artificially created, factitious. The third one, though, is the critical one. That's the persecutory delusion in the child. Does the child have a fixed and false belief that they are being malevolently treated in some way by the parent? And then where does that come from a child? Again, that's impossible. Children never develop a persecutory delusion towards a normal range parent. So where does that come? The shared or induced persecutory delusion. Okay. So it's really actually, though, a 1 symptom diagnosis, which is diagnostic indicator 3. Is there a shared persecutory delusion? Now, the assessment for a persecutory delusion is a mental status exam of thought and perception. That's what you should do. No one knows how to do that in the family courts. And if you go to people who do, they're in schizophrenia, they don't work with this pathology. So you're kind of stuck. I know how to do it. I can train you how to do it. I can tell you how to do it if you ask, but no one's asking because they're just ignorant, incompetent, and lazy and unethical. So I gave you a couple of additional symptoms on that to stabilize out. I will say all 3 of these symptoms must be present for an attachment-based model that I describe in my book, Foundations. If one of these symptoms isn't present, then you're looking at something else, and we'll deal with that. We can talk about that. If you've got 2 and not the 3, I would suggest you're not doing a very good job of collecting the symptoms, because I bet the third one's there. Because you got 2 impossible symptoms. So the first thing I did, I had the pathology in the family courts. Here's the pathology. It's the psychological abuse of the child by a pathological, narcissistic, borderline, dark personality parent who's creating a shared persecutory delusion and a false, factitious attachment pathology in the child for the secondary gain to the parent of manipulating the court's decisions on child custody and to meet the parent's own emotional and psychological needs. Holy Toledo, that's a lot to say. I don't want to have to say that every single time I talk about the pathology. So I need a label for that. That whole description, I just want a little label to use on that. So I decided to call it an attachment-based model of parental alienation. AB, attachment-based parental alienation, PA. Now, the reason I chose that is I put the word attachment at first so that we orient everybody to the nature of the pathology. We're not treating ADHD or autism or eating disorders. We're treating an attachment pathology. But then I had to use a word or concept that was familiar to you. Otherwise, you wouldn't know what I was talking about. So I used the term you guys were using at the time, parental alienation. Now, notice I have always put the term parental alienation in quotes because it is not a real pathology. The only reason I'm using it is because you folks are using it. It is my recommendation. It is my strong urging that everyone stop using the term parental alienation. It degrades the quality of mental health services in the family courts and creates just constant conflict and chaos. We need to bring the conflict around these children to a close, especially in the mental health people. The mental health people, there is no excuse for using this parental alienation term. No, stop it. Apply real knowledge. You're doctors. Don't make stuff up. There's attachment, there's family systems, there's delusional thought disorders, there's personality pathology. There's plenty of knowledge to apply. So just don't be rushing off to making up new pathologies thinking you're discovering something. No, we need to bring all mental health people should be applying the same knowledge to reach the same conclusions, the same diagnosis, and the same recommendations for treatment. If you go in with a medical problem to two different doctors, they should diagnose the same problem. If one of them saying you got cancer and the other saying you got diabetes, one of those doctors is incompetent. Okay. And so when you get a diagnostic discrepancy at that level, one of them is incompetent. So when doctors get together and talk about what the diagnosis is, we need to be talking about real stuff. Is there a personality disorder pathology here? Is this reached the level of Machiavellian manipulation? Is this a factitious disorder? Is it a shared person? We need to be having that professional level of conversation. Patients should never, ever, ever have to explain the pathology to their doctor. That is phenomenally bad. If a patient is explaining to the doctor what the pathology is, holy Toledo, that just indicates how bad and low the quality of professional practices are over here. And that's exactly what you guys are having to do. You're having to explain the pathology to the doctors. Whoa. And here you're going to have to explain how to diagnose it. Holy Toledo. But that's what this diagnostic checklist does, is it gives us a way to force them into a diagnosis. I'm forcing them to look. Is the child rejecting a normal range parent? Yes or no? Tell me yes or no. Because if it's yes, that's impossible. Is the child displaying narcissistic personality symptoms towards a parent? If yes, you have to explain how those arose. Is a child have a persecutory delusion towards their parent? If yes, you have to explain that. So tell us, are these symptoms present? Now, I have a form, a diagnostic, let me pull it down for a second. I have the diagnostic checklist for pathogenic parenting. So I didn't say use the word parental for pathogenic parenting. And I have, diagnostic indicator 1, diagnostic indicator 2, diagnostic indicator 3, and the 2B and 3. And then I even give the diagnosis down here. So if these symptoms are present, I kind of say, and then I give you the wonder of wonders, the 12 associated clinical signs. These are just gorgeous. They're not always present, but there's between 6 to 11 are likely to be present with this pathology. And then how do you get 6 to 8 associate clinical signs and 3 impossible symptoms? There's only one explanation if you get all of that. So just complete this. It's just a yes, no. So ask your mental health person, give me a yes, no. Or if they're just too scared by this form, just there's your 3 questions. Is my child rejecting me, and am I a normal range parent? Does my child have these narcissistic symptoms or phobic anxiety? But critically, is there a shared persecutory delusion? Yes or no? And by asking the question, they're going to have to look. And by looking, they're going to realize, oh my goodness, I don't know how to tell whether or not there's a persecutory delusion. And then they're practicing beyond the boundaries of their competence because that's what the pathology is. And so it's just amazingly bad. So this will show up their ignorance and incompetence, which is why none of them want to complete it. They will say, no, I'm not completing this because they are incompetent, and this will expose their incompetence. Last time, about 3 or 4 years ago, when I developed this and I said, go out and ask your mental health people to do it, parents were reporting back that mental health people were actually retaliating against them for parents who asked for the diagnostic checklist to be completed. The mental health person would say no, and then they'd write bad reports to the person and to the courts and stuff. They would actually retaliate against parents who were trying to get symptom information from the child. That's how bad things are over here, because this provokes a narcissistic injury. It exposes their inadequacy and incompetence. So you're going to provoke a narcissistic injury, so they're going to retaliate against you. Mental health people should never be retaliating against their patients. They should never be a danger to their patients, but they are. You should never have to explain a pathology to a doctor, but you do. It is so bad over here. But the way to get, I'm senior staff, the way to get this back on track is to get, first off, clean documentation on the symptoms. So because symptoms, diagnosis depends on the symptoms, and so the first issue is, what domain of pathology are we in? Attachment pathology. Here are the symptoms. Tell me these symptoms, and if it's the pathology, if these symptoms are present, there's only one explanation. If somebody wants to come up with a different explanation for why 3 impossible symptoms are present, they can give it a try, but there's only one explanation. And so it's as simple as that. Easy peasy. But the mental health people in the family courts are refusing to do that. And clinical psychologists don't work in the family courts because it's too professionally dangerous. It's too professionally dangerous for me to work over here. I'm getting sanctioned on my license for trying to help you people. And so that's insane. Dr. Childress comes over here and says, everybody needs to be ethical, and they sanction me. Okay. They don't want to solve anything over here. It's a cover up and collusion by the AFCC, cover up by the licensing boards, and basically cover up from lethargy and apathy from the American Psychological Association. The pathogen, this trauma pathogen, has infected the mental health system and is disabling the mental health system's response to the pathology in the family courts. And so we need to cleanse the mental health system of the pathogen people, the mental health people who are pathological. And if you want to, but there's specifically people in specific positions. If you want to know who they are, who did the APA give the petition to the APA to? So here we got the petition to the APA. No. Yes, I have here. But the petition to the APA, hand delivered it to the APA. Who did they give it to? They gave it to a committee of forensic psychologists, I suspect. And I suspect I know who they are. But just get them to identify who they gave it to. It's been 5 years, and what's the outcome of this? Those are the people who are disabling the mental health system response to this pathology in the family courts. You want to know specifically? Find out what happened to the petition to the APA. That will tell you specifically who is disabling the mental health system response. Now, the other feature about all of these 3 diagnostic indicators is that I keep referring to a normal range parent. The only cause of severe attachment pathology is child abuse. It's either child abuse by the allied or the targeted parent, who is somehow abusing the child and creating the child's attachment pathology towards that parent, or it's psychological abuse by the allied parent who's creating a persecutory delusion and false, factitious attachment pathology in the child for secondary gain to the parent of manipulating the court's decisions on child custody and to meet the parent's own emotional and psychological needs. So it's either going to go one way or the other. It's either child abuse by the targeted parent or it's psychological child abuse by the allied parent, shared persecutory delusion, factitious. So we know that. We know that going in. That's the only cause of attachment pathology. So let's get a differential diagnosis on that in all cases, because that's the only cause of attachment pathology at this level. So if you have a court-involved custody case where the child is displaying severe attachment pathology, a child's rejecting a parent, we need to get a proper risk assessment for possible child abuse to the appropriate differential diagnosis for each parent. So we start with the targeted parent and say, are they abusive? And if they are, then everything stops and we put that on a treatment plan and that becomes our focus. If they're a normal range parent, then we shift over and say, is there a shared persecutory delusion, false attachment pathology? But then how do we define operationally a normal range parent? Oh, so first off, so either the shared delusion disorder or the false factitious attachment pathology both wind up at a child psychological abuse diagnosis. Okay, so the shared persecutory delusion creates the false factitious attachment pathology, and both of those individually and together are a child psychological abuse diagnosis. And that's the critical diagnosis because that's the diagnosis that's going to guide treatment. If we have child abuse, then we're into a child protection response, and we need to recognize the severity of the situation that's involved, the severity of the pathology. This is not anywhere close to a normal pathology. We need to get in there and start doing a child protection response. So either one of those and both are going to result in that child abuse diagnosis. So then the only cause of severe attachment pathology is child abuse by one parent or the other. Either it's a targeted parent abusing the child, or it's child psychological abuse by the allied parent. Attachment-based parental alienation. Now, the pathology lies about everything I do. It's a pathology of lies. So it's going to one thing it's going to say is Childress has some new theory. No, I don't. It's the application of established knowledge. Anybody who thinks that I have a new theory is simply exposing their ignorance for the actual knowledge and no, there's no new theory. I just use that label just so I don't have to say this stuff all the time. I've created another label, Bob, brutally obstructed bonding. So you can call it ABPA, you can call it Bob for all I care. It's a shared persecutory delusion and factitious disorder by a dark personality parent for secondary gain. Okay, that's what the pathology is. So, what's a normal range parent? That's where I developed the parenting practices rating scale to give us an answer on this. Now, again, these are not assessments. These are simply documentation instruments. We start cleaning up the system by just getting documentation of what the symptoms are. So what are the child's symptoms? But then the first one, attachment pathology towards a normal range parent. What's a normal range parent? Is that a normal range parent? So I have the parenting practices rating scale, and I have every possible type of parenting practice that they could come up with. And the clinician just does a clinical assessment. I recommend applied behavioral analysis, but you just do a clinical assessment and you figure out what's the parenting practices of this parent and rate them into one of four categories. And you rate them really specifically, but then we collapse the categories because there's really only two. We have abusive range parents and normal range parents. Now, on the parenting practices rating scale, level 1 on the first page are all the abusive parenting practices. So if this targeted parent is abusive, and this is for the targeted parent, to see if they're normal range. If they are abusive, just check off what their abuse is, and then we'll have know and everybody's clear, and we'll put that on a treatment plan and fix it. If it's really problematic, but it's not quite abuse, but boy, are they a hostile parent or over control? I don't know what it is, but it's really severely problematic, but it's not abuse range. That would be level 2, severely problematic parenting. Level 3, though, becomes normal range problematic. Parents aren't perfect, and parents do stuff, and so, but it's normal range. It's just kind of what happens in the world. Normal range problematic parenting. We maybe put the little problem on a treatment plan, but their parenting is not responsible for this level of pathology. Or level 4, which is normal range and healthy. It could be a little bit more structured, could be a little bit more permissive, but it's normal range and healthy parenting. So then we collapse it into, are they level 1 or 2 or level 3 and 4? If they're level 3 and 4, they cannot possibly cause symptom 1, the attachment pathology towards a normal range parent. Normal range parent, level 3s and 4s, do not create a child rejecting them. They create insecure attachment pathology at level 3, maybe. They create insecure attachment pathology at level 2. You can create insecure attachment pathology at level 1. So we don't really ever quite see a child rejecting a parent, ever, because it's a goal-corrected motivational system. I will flex and allow abusive parents, say that yes, we need to. When we have severe attachment pathology, our first rule out is that the targeted parent is doing something abusive with the child, and we need to get a clear diagnosis. When child abuse is a considered diagnosis, which it is with this pathology, because that's the only cause of a child rejecting a parent. So child abuse is a considered diagnosis with this pathology all of the time, every case. So when child abuse is a considered diagnosis, our diagnosis has to be accurate 100% of the time. Misdiagnosing child abuse is devastating to the child. We cannot allow that to occur. And we can do that because diagnosis isn't just a one-off. We got all sorts of ways, response to intervention, all sorts of stuff we can do to make sure our diagnosis is accurate. But it has to be accurate 100% of the time. One of the things I suggest is you always pull in a second opinion consultation. Always, always. Because the appellate system for a disputed diagnosis in healthcare is a second opinion. I can pretty much guarantee that this diagnosis in the family court system is going to be disputed by one party or the other. So rather than get a diagnosis and then dispute that and get a second diagnosis, and they might be using different constructs and just have let's do it at the same time. That's what doctors do. You go and you say, doctor, this hurts. They say, let's get you an orthopedic consult right away. Because as doctors, we need our diagnosis early and accurate because we need to do treatment. So we pull our appellate system, second opinion, right up front. And so the courts should just kick it out to the mental health people and say, get me a diagnosis on this. And the mental health people then need to return an accurate diagnosis that the court can rely on. The way we do that is we get second opinion consult, maybe even third opinion consultation. I'll be starting up the consultation groups again in the fall. So that should always be happening in the family courts, and that's one of the ways to improve this. And so you just then, both of those mental health people decide whether or not these symptoms are present and whether or not the parenting is normal range or abusive range. Then they provide that information to the court, and the court can look at it too, and the court can decide, because this is pretty gall darn simple. There it is. Court can look at this and say, yep, these symptoms are present, and yep, that's a normal range parent from all indications. So we're looking at this child protection response. But courts are not responsible for diagnosing pathology. That's the mental health people. That's the failure of forensic psychology when they left the clinical field and started doing something different. We don't diagnose pathology. We don't because now they're not giving the courts the diagnosis, the accurate diagnosis of child abuse. The forensic psychologists are not telling the court that there's child abuse when there's child abuse. They're withholding that information from the court. Why are they withholding it? Because they're not even looking for it. Oh my goodness gracious, it's so bad over here. So when it comes to people saying it can't be that simple. Yes, it is. In fact, it's simpler even than this. It's just diagnostic indicator 3. Is there a shared persecutory delusion? That's the question they need to answer. And what these instruments do is they document uh, the symptoms. They make them look. Okay, so if you say, "Give me an answer to the diagnostic indicator 3, is there a shared persecutory delusion in the child?" Then they have to look and answer that question. And when they look, they're going to go, "Yeah, actually, yeah, there is." But right now, they're not even looking because they're just like ignorant like a rock. And so those are the instruments. I recommend that they just be conducted routinely. There is no reason not to conduct, to just fill these out. There's real simple instruments. Just check, check, check. Takes 2 minutes from the mental health person. Even if they don't agree with Dr. Childress, even if they think, it's caused by a new pathology like parental alienation or, because, it's Tuesday. I don't care what they believe. Just give us the answer to these questions, please. If it's no, it's no. Okay, that's fine. But tell us, are these symptoms present? And right now, the mental health people that you're working with out there are just going, no, I'm not going to tell you what the kid's symptoms are. Well, then how can we get a diagnosis out of you? If you're not going to diagnose the pathology and the pathology is possible child abuse, and we need to know the diagnosis, then you're kind of a pretty irrelevant mental health person. Okay, go away, because we need a diagnosis of possible child abuse here. So we need to find somebody who's going to give us that. And if that's not you, then you're irrelevant. Go away. And so every mental health professional has duty to protect obligations. Every mental health professional has ethical obligations under their ethical standards from a master's level, and social workers and psychologists for competence. We are not allowed to practice beyond the boundaries of our competence. This is a delusional thought disorder. I will cite to Walters and Friedlander 2016 in the Journal Family Court Review. They are aware this is a potential persecutory delusion. So they then need to assess for it. The assessment for a persecutory delusion is a mental status exam of thought and perception. So if they're going to argue with me, then do a mental status exam of thought and perception. They don't know how to do it. Well, then get out of the field, because you're incompetent working with delusional thought disorders. Because you have a the mental health people actually do have a delusional thought disorder. It's an absence of linear logical reasoning. Simple, I'll wind up here, but a simple way to demonstrate the thought disorder in the forensic psychologist. You say, what's the diagnosis? They say, I don't diagnose pathology on all their custody evaluation. I don't give a diagnosis. Next question. How do you know whether you're making recommendations for cancer or recommendations for diabetes? If you haven't identified whether it's diabetes or cancer, because those have different recommendations. How do you know whether you're making recommendations for child abuse by the targeted parent? Is that what your recommendations are? Or are your recommendations for child psychological abuse by the allied parent? Because that's the only two causes of attachment pathology. You know that, right? No, they don't know that. And then they just go crazy. So, So with that, I'm going to wrap up today on the discussion of the diagnostic checklist for pathogenic parenting and the parenting practices rating scale. If you use these two together, you will for a fact 100% accurately diagnose the pathology, and you will never, ever misdiagnose it. Because if the allied parent, if the targeted parent is abusive, first off, they don't meet criteria one. They're not normal range, and you've documented it on this. So if they're not a normal range parent, they don't meet criteria one. Second, you don't see narcissistic personality symptoms towards an abusive parent. You don't see a child who's being abused have a haughty and arrogant attitude and a judgmental attitude and a cruelty, an absence, the cruelty towards that parent. And, no. If a child is being abused by the parent, they are afraid. They are compliant. They are totally different. I work child abuse. I've personally treated all four types of child abuse, and I have personally led the treatment teams for all four types of child abuse that have included CPS social work involvement. CPS would send their social workers to my clinic in our conference room for their meetings on case management. We'd have the parent in and the parent support person, whoever that they wanted to bring. We'd have my therapist in. We might have a school teacher in. We'd have the CPS social worker in. The only thing CPS said was if the parent were to bring an attorney to one of these meetings, they would like 48 hours notice so that CPS could bring their attorney. Notice how specific I'm aware of this stuff. I've worked child abuse and trauma. I know attachment pathology. I know persecutory delusions. And I'm senior staff, and I'm here to kind of clean up the mess that's absolutely over here. The diagnosis guides treatment. So we need to move this off of custody and move it back to treatment. The whole custody thing is false. It's not about custody. Custody is easy. Are you kidding me? It's either 50, some variation of 50-50, or it's some variation of every other weekend and school week primacy, or if it's distance, it's school year for one and vacation time for the other. There's really only three, and really only two if they're in the same area. It's either 50-50 or every other weekend. It's not a custody issue. The only reason it's a custody issue is if we have attachment pathology, a child rejecting a parent. That's a treatment issue. So let's get it out and get it diagnosed, identify what the problem is. And diagnosis then guides treatment. If it's child abuse by the targeted parent, put that on the treatment plan and that be it. If it's child abuse, psychological abuse by the allied parent, put that on the treatment plan and fix it. But let's figure out what the pathology is. For the diagnosis, I want to get that. Diagnosis depends on the symptoms. You tell me the symptoms, I'll tell you the diagnosis. Doctor, this kind of hurts. Well, let's find out what your symptoms are, and I'll do a pattern match of your symptoms to the diagnostic criteria. And that's what diagnosis is, a pattern match of symptoms to diagnostic criteria. So let's collect the symptoms, and so we can do a pattern match and see what the diagnosis is. And there's additional things we can do. Response to intervention is one of the primary ones. Consultation is very helpful. That should be standard of practice over here. It's not. So we're going to be in a transitional phase when we're cleaning house. If this was a clinic and I'm being brought on to the family courts as my clinic, I'm firing all the staff. All the staff, everybody who works right in the family courts right now, all the mental health people, you're fired because you're ignorant, incompetent, unethical, and lazy. And 80% of you are participating in child abuse. And the 20% that aren't are simply failing in your duty to protect obligations. So 100% of you are getting pink slips. And we're going to get dialectic behavior therapists over here. Get dialectic behavior therapists, emotionally focused attachment therapists, but it needs to be within the context of a strong personality disorder therapy, and that's dialectic behavior therapy. It's going to have to be adapted to the courts because it's not there, because clinical psychology doesn't ever treat this pathology. We don't have any treatments for it out there in the real world because it doesn't exist in the real world. It's a factitious pathology that only exists in the family courts. And these forensic psychologists only exist in the family courts. We need to get rid of them. Cite to the New York Blue Ribbon Commission on Forensic Custody Evaluations. Forensic psychologists need to go. And then clinical psychologists need to come back. They won't come back. It's too dangerous. They shouldn't come back. It's too dangerous. So we need to develop a standardized assessment, a diagnostic assessment protocol, so that all clinical psychologists can follow the assessment protocol, and then they will be safe. And second opinion consults will be safe. So we need to make it safe for the clinical psychologist to come back. The legal system needs to think about how they make it dangerous, their adversarial system. I would suggest we get a pilot program for the family courts. Easy peasy. Get the state legislature, fund university for their participation in the research evaluation of it, and you put together a pilot program for the family courts where you come up with a diagnostic assessment protocol for the pathology, you come up with a treatment protocol for the pathology, and you come up with the legal arguments in support of a treatment-oriented approach, and we end the fighting around these children and fix the problem. Treat the pathology. So with that, that's my Sunday morning coffee for this week, and we'll talk with you later. Take care, everybody. Bye-bye.